The Australian health system is a world-class, accessible model of healthcare that is also a complex and expensive system to sustain. With an ageing population that has an increasing life expectancy, low acuity and chronic illness are at the forefront of the increasing strain on our primary healthcare system. In Australia, the need for more efficient and cost-effective healthcare models has led to the introduction of an extended scope of practice for paramedics who historically contributed to primary healthcare in the pre-hospital environment. The proposal was to extend roles for paramedics within regional and rural Australia in combination with physician-assisted skills to deliver innovative clinicians for pre-hospital and hospital primary healthcare environments. So what are the expanded roles for paramedics? Current paramedic divisions in Queensland are mentioned in the QAS Clinical Practice Manual. These include the Advanced Care Paramedic Level 1 and Level 2, classed as ACP 1 or 2. This is the standard level of paramedic and formulates the majority of paramedics who complete a 3-year bachelor. Over the years, this base level scope of practice has expanded from the use of basic drugs such as paracetamol and methoxyflurane to the recent introduction of droperidol. In rural locations, there is the formulation of an extended care paramedic or extended scope of practice paramedic. These paramedics will be discussed in more depth later. After the base level paramedic, a more experienced professional called an intensive care paramedic was created. This skill set required a master's degree and extensive training in higher risk procedures such as endotracheal intubation. There are also 2 other extended roles within the ambulance service that branch off. These are the Low Acuity Response Unit and the High Acuity Response Unit, commonly known as the LARU and HARU. The HARU branches off from the ACP 2 level paramedic, while the HARU branches off from the intensive care paramedic. In this presentation, we will focus on the extended care paramedics and LARU units because these units have been developed in response to the increasing low acuity workload on our healthcare system. Firstly, extended care paramedics are equivalent to ACP 2s, but with additional drug and skill attributes. Extended care paramedics specifically operate in rural and remote areas where there is the high requirement of working autonomously and medical resources are low. In regards to extended drug scope, extended care paramedics can administer hydroxycobalamin, ibuprofen, and magnesium sulfate. Hydroxycobalamin being an antidote for cyanide toxicity, ibuprofen being a non-steroidal anti-inflammatory used to treat moderate pain, and magnesium sulfate, which is an electrolyte that is used to treat a variety of ailments such as severe or life-threatening asthma, eclampsia, and Irukandji syndrome. The additional skill set of an extended care paramedic contains the ability to perform invasive blood pressures, infusion lines, operate Alaris pumps, operate 2 kinds of syringe infusion pumps, skin stapling, and skin taping of lacerations. ECPs are highly trained paramedics that play vital roles in the continuing of health and well-being in rural and remote communities, not only in Queensland but throughout Australia. The Low Acuity Response Unit program was originally established to treat non-urgent patient requirements, which have placed an increasing strain on emergency service resources. This unit is used to optimise resource use within the ambulance service and increase the ability of paramedic crews to critical cases. LARU paramedics have the ability to refer patients to GPs or other health services rather than adding additional strain on an already heavily used emergency service. Specific job requirements that are met by the LARU team include minor medical problems, superficial burns, minor lacerations, non-serious fall-related injuries, and chronic illnesses in need of medical assessment. The LARU team therefore provides an in-the-field triaging component that has been created to potentially help alleviate the growing workload placed on emergency departments and hospital ramping. So how will this influence my practice as a paramedic? As a graduating dual degree of both nursing and paramedicine, I feel that the expanding scope of practice of the paramedic role will see the blurring of the two lines between the community-based service. This will be shown later with evidence, but this is not a new concept and has already started to develop into fruition through the extended care paramedic and LARU roles. I am excited about the prospect of this development because it means that I can develop both of my degrees within the public domain and not be restricted to one field. Nursing provides an extensive knowledge base of chronic public health conditions and the treatment pathways involved, as well as some of the skills already used by the extended care paramedic are base standard skills of a nurse. Whilst paramedics provide the acute life-threatening aspect, they can often see new graduates run down and burnt out within years. I feel that these expanding paramedic roles will influence my practice in a positive way by encouraging me to develop and expand on both my degrees within the rural environment. Now let's evaluate this using evidence. Evaluation of the health system has shown that rural and remote locations of Australia face limited access to services whilst facing difficulties in recruiting and retaining healthcare professionals. This means that there is less healthcare workers to deal with an increasing workload. However, pre-hospital care providers have found that the nature of the workload has been primarily non-emergent interventions. In fact, up to 50% of patients transported to emergency departments were discharged without significant treatment or referral. In seeing this trend develop over the last decade, new prototypes of healthcare providers have been introduced to respond to the evolution of local service needs. This has shown a shift in the levels of education and skill set of our pre-hospital professions into the tertiary sector. These new paramedic models incorporate the chain of survival concept while increasing the depth of treatment and clinical decision-making, whilst also including more primary healthcare activities than a traditional paramedic role. So what are the findings discovered through this research? Extended scope paramedicine is not a new concept, with international countries developing this model for over a decade. Community paramedicine is characterized as the utilization of extended scope paramedics who provide flexible, proactive, and preventative new services to communities. Countries such as Canada, United States, and UK have established programs that provide scheduled preventative home visits for chronic disease management, or to refer patients to community care services to prevent future unnecessary emergency calls. Australia's response to this situation is the development of the extended care paramedic and the LARU service. These paramedic roles provide a more focused scope of skills that directly targets the ever-expanding healthcare problem that has been predicted for the future. So what does this all mean for my practice, and how will this shape my career path options? The possibilities for the future of paramedicine are endless. With the requirement of a broad knowledge base in medicine, it can be seen that the extended care paramedic skills will evolve to incorporate advanced diagnostic and treatment skills. As a future graduating paramedic, this means that the possibilities of a continued life learning opportunities will be expanded into a possible physician-assisted role within rural regions. This also means that it is more important than ever to remain vigilant with personal and professional growth within the medical field in order to ensure my practice is backed by current evidence-based practice.